try that again. Good morning. It works. Now you have to look south a little bit, okay, to the north of Spain, where we took more or less the same decision, more or less at the same time, 2008, 2009. Sorry, the computer's falling. There we go. Which was, we were not expecting that the central government was going to see the light. And since you have a certain level of autonomy, we decided to go ahead at the Basque region and move forward with the agenda that brings us together. And actually, right now, I think there's about half of Spain moving in that direction. We have the Catalans here advancing fast as well. Other people in the room as well. Thank you, Nick, for having us here. WHO is also trying to energize this agenda from the European office and the central office. And I think that's very welcome because it provides sort of an international alignment, which was, I think, missing. I think what I'm going to explain is, I think, another intent, at least an intent of alignment between the macro, meso, and micro level, something where things have to be aligned so all the stars are looking in the same direction. Otherwise, it's very hard to pull off integrated care if the center is not saying what it thinks it's important, the middle management is not really energizing that agenda, and the local level is trying to pull it off. So actually, what I want to expand on is a bit of that. I think we know we're all perfectly fragmented systems, so I won't go very much into why we're there because we all know why we're there, and we've done probably enough group therapy on that through the years, and that's probably enough. So it's time to move, as you heard before, it's time to move on to the solution side. As you know, in the past years, there's been a move just in medicine, forget integrated care and other stuff, just medicine, from what used to be called intuitive medicine, where you pack somebody with an antibiotic hoping it was going to hit the right germ, or you do a massive chemotherapy on something, to now more precision medicine, where you can be more precise with drugs, with technology, and you can go slowly, but we're going towards personalized chemotherapy, personalized treatments of all types. That move from intuitive medicine to precision medicine, the Christensen logic, I think can be applied as well in management. I think we've moved from a moment of anybody could be a manager to, in the last years, a very sort of precise battery of tools that we can be applying to bring things together. And I think that can be called precision management. Let me just give you some ideas. I mean, for example, I think we're all using the frameworks that everybody has in mind, the Wagner chronic illness model, the Kaiser Permanente risk stratification, and the triple aim that Derek Feely has just explained. Those three mental structures give us, I think, the intellectual frameworks to be more and more precise and to actually think in system terms and start aligning the three levels I was talking about. We didn't have those before. Now they're there, and they're being used by thousands of people very successfully. And we're becoming more and more attuned and precise with their use. Just risk stratification, there's 5 or 6 countries that now have moved forward in Europe on risk stratification. That's the real stratification in the Basque Country. And the message here is that if you have, and we almost all have good information systems in Europe, you can do this in 2 or 3 years. You can quickly stratify your population. And if you can start stratifying your population, you can be more precise, you can target, and if you can target, you're beginning the journey towards population management, which is the journey we need to move to. We've become much more precise with all the teles of the world. We can tele just about everything. One word of caution on that one. I mean, I think the ICT are going to be key, but we are going slowly towards what I could call telesilos, in which we start getting, we start using ICTs to reinforce the fragmentation rather than ICTs to bring things together. So if you're going to move on ICTs, make sure each of the ICTs is not a next telesilo. It's something which brings the pieces together. That, among other things, of course, it's the EMRs. It's all the things that we're going to be discussing these days on integrated care. There's more and more precise information about that. We know now how to empower patients more and more, thanks to them mainly, their signals. Managers are beginning to pick up on how to do that in a much more precise way. The electronic prescriptions are a bit all over and are being very, very useful to bring things together. So in a certain way, they are also, all of these elements are all integrators. And I just want to stop on one, which I think is beginning to become extremely important, which is the new payment systems. All the other ones were sort of, let's bring things together at the delivery level, which is the agenda that was pending. But the people paying, whether it's private or public system, the people paying are also, of course, beginning to get nervous. And they're beginning to say, if there is some efficiencies I can pull off from integration, why not do it? Why not interiorize that within my payment system? So in the Basque Country, we were beginning to move on 3% of the budget in that direction, others as well. In the US, there's a whole bunch of experiences now. In several European countries, there's more and more experiences with bundle payment, global payment. So the signals from the payer are also going to be about integrated care, and I think that's going to galvanize part of the change. It's I think, highly unlikely that if the payment systems stay the same, the delivery level is going to want to do some of these things. So I think it's very encouraging to know that some of the information about patient improvement and outcomes, plus the efficiency logic, which underlines the triple aim, is beginning to appear in the payment methods, but only beginning. But I think and I think, again, that's another place where we're beginning to get precise. So I think that's another example. What we did in the Basque Country is took all those things and we said, okay, what integrates and what fragments? What integrates is a certain amount of things which could be called top-down interventions. So we decided those are top-down interventions. Risk stratification, well, it's done with, of course, the resources in the human resources, but it is something which has to be more or less the same across the whole Basque Country. Call center, well, let's look for scale, let's do it for everybody. The EMR has to be more or less the same, of course, across the country. So, and other things like electronic prescription. So these are, I would say, unashamedly top-down interventions that if you have the power at the macro level to do, just do them. Because you have the tools to move it forward, and why not just introduce them? Because most of them, when you think of them, they are all integrators. If you don't have them, well, don't expect miracles. The ones that we did not know how to do, but that we did know, I had an organization of about 30,000 people. Everybody's salaried, primary care, hospitals, etc. An NHS beverage type of system in Spain. We said, well, let's launch a very ambitious bottom-up exercise. For various reasons I'll be explaining. But the things we did not know how to do, we didn't know exactly what case nursing meant. So we asked the staff to say, well, what shape would you give that? And we asked people, what shape would you give patient empowerment? We think you're going to give us a better tool than the one we have. how do you integrate care? Why don't you tell us how you would integrate care in different parts of the Basque Country as you move forward? All that going towards the triple aim all the time. You see, the triple aim got pretty mixed up there in the center, but actually, for some reason, the word efficiency came up stronger than population health. Maybe that's the way I was thinking. The important thing, I think, though, is that if you do find a new balance between top-down and bottom-up, you're actually calling for all the energy and all the resources in the area. If you do everything top-down, which is traditionally the way we do things in Spain, and actually that's what when you're given power, that's what you feel like doing, because you're in a hurry and you have a crisis and everybody's asking for results, so you tend to want to do everything top-down. There's a moment in which you have to say, look, I'm not going to top-down everything. I'm going to bottom up a whole bunch of stuff. That may not be new in your countries, but it is very new in Spain. And people, I think, at the provider level found that an interesting signal from the top. Now, where I want to go in the rest of the intervention is, okay, so we did that, the tools are there, we can be more and more precise, let's use them. They integrate, and a lot of these organizations are taking shape. The shape they are taking is we're beginning to know how to manage systems. We're beginning to know how to manage systems instead of just managing structures. The word community system or community delivery system or community integrated system is picking up speed here in the States and other parts of the world. And it doesn't have to be one single agency managing that in the community, but as Derek says, there has to be the function of integration. You don't have to think of a person, but the integrator that he was explaining, that function has to be there in some sort of local agency. And there, of course, there's thousands of different models that are going to appear in which you can package things in different ways. But again, it's bringing the people of the community into a population agenda in which they were not participating before. As we move forward in those systems, we started getting in the Basque Country some pretty interesting results. We got less hospital admissions. We have better first visits sites. We have lower referral rate for medical consultation. So basically, primary care was beginning to take, and home care was beginning to take a better understanding of controlling a certain amount of chronic patients before they got worse with one way or another. The same thing with different other tools that are there in the webs, and that my colleagues here from the Basque Country that talked about this yesterday, and others can give you more detail about. But basically, we're beginning to get good results across a whole battery of diseases. Now, the problem then for us, I'm the little guy. Okay. Or the little guy is a pilot experience that you're doing. Why is it so hard, even if you're getting really good results, even if you have a certain amount of alignment across the three levels, macro, meso, micro, why is it so hard to scale this up? Well, because of the big guy. Those resistances are there. I'm a doctor, but normally those big guys are called doctors. And they're there, and we have to bring them on board. We have to try to ensure that they are not alienated by this change agenda, and that they understand, even extreme specialists in hospitals, they understand that this is about community health from now on, and that we're in the middle of the most important paradigm shift and transformation shift of the last 35 years. Many of them are comfortable in what they are, so we have to make it interesting. So if you want to scale things up, at least what you have to do is, I think you've heard Derek, and what I did at least was take this up to the policy level. So don't play around with chronic care and a few pilot experiences. This is the policy intervention: chronic care, chronicity, and integrated care. This is what you do at the political level, and you put your political weight behind it. I didn't have much political weight because I was an independent, but I got some, and I got some support, so I just used that power. But I took it to Parliament, and so chronic care, integrated care has to be up at the policy level. You have to take it up there somehow. You have to give it political weight, and then you have to, for 4 years or 5 years, or how many years you are there. I was asked to leave after almost 4 years. The idea, but not because of this, okay? If any of you are, this isn't the reason, just some people lost the elections. The important thing is stick to it. Just stick. And you need, this is long-term stuff. Now, what has to happen, and what all of us have to know how to do at the policy level, is manage 2 agendas at the same time. One which could be called a resist culture. One which you're doing things on salaries of human resources and doing things with a pharmaceutical budget, and you're basically trying to control cost and improve quality in whatever way you do it, and you're trying to do things in every day. But the big problem with a resist culture, if that's where you stay, if that's what you're going to do the 4 years, is that it doesn't change anything. So it's pretty dramatic to be given power, to know that you can do a whole bunch of other things and just stay on a cost containment agenda or on business as usual thing. So but that agenda is alive, and that's the one that takes you to the media. That's the one you have to go and answer questions in Parliament all the time. That's where they capture you in day-to-day. But at the same time, if you launch, as we did, a more of a transformation agenda, you start introducing a transformative culture. And I suppose the people in this room are transformative culture. Now, what's good about that one is that it does change the status quo, but it's the big guy, and that's really tough. Now, I'm introducing here today in EJIC a new definition of integrated care, which basically means you have to manage 2 agendas, change everything, but without screwing anything up. Now, what is important about this is that as you manage the day-to-day and you do the transformation agenda at the same time, you have to protect groups which do the transformation agenda. You cannot get them into the daily firefighting. So in change management terms, you have to get people just full-time on the transformative agenda. As I said before, some top-down stuff is necessary, and you have to find out, because a lot of people now say, okay, well, everything has to be bottom-up. Well, no, I don't think so. We heard an example of a certain level of orchestration. There are many others in Europe. At the top level, there has to be some orchestration and some ways of making sure that you launch it. But it has to be done looking for commitment rather than compliance. So we decided at the first instant not to legislate on this change because we thought it was a cultural change. It might have been wise to legislate that, to accompany it, but we decided not to use the legislative tool at the beginning. But you know, one should not discard it if one has the power to do so. The key element of orchestration, also from above, which is going to take, I think, a lot of weight soon, is the payment reforms, the way we finance that. And it's good because it keeps you away from micromanaging. Because, you know, I don't know about you, but in Spain we love to micromanage when you're at the top. Well, actually, we micromanage wherever you are. If you have the policy intervention, you know what you want to do, and you have some orchestration from above, you have a clear idea, and the payment mechanisms are probably going to be important. Then we launched the bottom-up, and with this I'll be finishing so we can have a discussion. But basically, what we've all tried to do in many countries, and what I was trying to do is what could be called this high involvement culture, where you bring the health professionals. I'm the first one who says, of course, like everybody else, we need to get the patients on board, we need to have their voice, we need the empowerment, etc. But as we move towards patient empowerment, we mustn't lose the professionals on the way. Because the professionals are the ones who are going to help you move this forward or not help you move this forward. Patients, of course, as well. But being where we are, the professionals have to come on board. So in one way or another, we have to identify some way of involving. And the evidence says that the more we involve, the more staff engages, is Weston Dawson, England stuff, but basically, the more we engage health professionals, the better it is for just about all the indicators, even the financial indicators in the hospital, quality, mortality, patient satisfaction. So if the evidence is telling us with a certain amount of precision, involve doctors, involve nurses, involve pharmacists, involve psychologists, involve all the professionals in there. Well, I think it's very important. The best way, I think, to do that is introducing a bottom-up logic in management terms. If you bottom up some of this stuff, they get on board. If you top down everything, they don't get on board. Actually, I don't think patients will get on board if you do everything top down either. Now, so if we want to address the scalability, take it up to policy, make it policy, move many levers, make sure all the levers are integrators, because some of the levers a lot of people are pulling are actually fragmenting today, because you can have different payment systems for hospitals and for primary care. So if you do that, you're fragmenting. So if you're moving the levers, they should all be levering in the same direction. New payment schemes will galvanize change. Efficiency drive, I think we'll have to find some sort of shared saving arrangement with health professionals in order to bring them on board. So shared savings, a lot of bottom-up, will probably help to bring professionals on board. Pilot schemes, yes, and then generalize them. But maybe what we were trying to do, apart from this logic of let's find out what a pilot can pull off and then maybe generalize, what we were trying to do is something a bit further, which could be called self-discovery. I don't know in your parts of the world, but in my part of the world, if you invent something, if you find something and you know how to do it in San Sebastian, the people in Bilbao don't want it. And vice versa. So even if your pilot in San Sebastian has worked really well, these guys don't want it. Nobody has really good outcomes. I don't care. I don't want it. So what you have to do is launch a lot of self-discovery from the bottom and let everybody self-discover. And that means launching bottom-up, but permitting local innovation, unlock the benefits of local healthcare innovation, and let the health professionals and the local managers identify their way forward. And lastly, our friends from South America and Latin America have a saying that they say, love without a budget is not true love. I know that doesn't sound very good in terms of men-woman thing, okay, or men-men or whatever you are. But basically, in healthcare management, if your plan is chronic care, integrated care, you're going to have to put a lot of your budget on it. And it's, of course, much better if the budget looks like the big guy than the small guy. Okay, thank you.